Okay, also, we will be recording. I think we can go ahead and start so that we have a very full and robust meeting. Um, Thank you again, everyone, for joining from all over. Can see members of our team from across the globe and people who are well versed and known in global surgical care. I'd like to just welcome everybody to today's session. The Paul Farmer Collaborative is a collaborative in honor of our esteemed mentor and global surgery champion, Paul Farmer, who means a lot to us within the space, within UGHE and the University of Global Health Equity in Rwanda and the Harvard Medical School. And so across both institutions, on a number of levels, there's a lot of work that is being done collaboratively in that honor. And there are funds that have been raised to be able to make sure that work goes on, that promotes equity, promotes bilateral exchange, and gets the kind of work that Paul Farmer lived for done across both institutions. One area, one tier of that work is within the research space and the exchange space. And this is one point of contact for the Harvard Medical School and the University of Global Health Equity, particularly through the program in global surgery and social change and the Center for Equity in Global Surgery. So we'd like to welcome you to this. Just to say that we will be having 5 sessions of this, one each month. And it's going to be a session series that will explore methods and outcomes of global surgery research. I'd like to honor Dr. Bethany Hetgothia and others who founded and started this out a few years back. And it's eventually has expanded to be across both institutions. But the idea is to be able to focus on certain methods and certain outcomes and ways of expanding research and teaching and learning across components by bringing speakers on a similar topic, 2 of them, to speak about the papers that they have written and to give us discussions on implications of results, etc. And then for people to actually ask questions and learn from this. We have videos for each of the seminars, and they'll be posted immediately, or at least a few days after, but just stay posted, just stay tuned. We have videos that will be ready for everyone. This is the team of individuals who have been coordinating the research seminar. The faculty leads are Dr. Adeline Boatin from the program in global surgery and social change, Dr. Bethany Hetgothia, also from the program in global surgery and social change, and Dr. Piret Mukundwa, who is from the Center for Equity in Global Surgery in Rwanda. We have a few fellows that have been doing a lot of work on this, and we'd like to honor those from PGSSC, Jiwa, Afra, and Taylor Werderman, and the CEGS leads who are Masters in Global Health Delivery learners here, Alex Haptamariam and Sarah Derricks. So this is the powerhouse behind a lot of the work and a lot of the things that we will be doing. Now, before we move forward, I'd like you to just type in the chat where you are coming in from. Just help us type where in the world you are into the chat. Thank you, Boston. And I know Boston is for everyone. Great to see you, Babatar. The whole team that's there. Yeah, we've got New York, Brazil. We've got Butaro, Connecticut, New Haven, Kigali. Yes. So keep it coming. Keep it coming. Greece. Wow, it's great. Let's keep that coming. Now, so welcome from all over the world, and let's see what our count is at the end of the day. I'd like to make welcome our very first speaker here. Rennie Chin is well known to those of us that are within this space. She is a general surgery registrar from New Zealand and has completed a Master's of Public Health at the Harvard Chan School of Public Health and a PGSSC fellowship as a Fulbright scholar. I had the opportunity of working with her over the years that we were together in the program. And as an immigrant from a low-income, multi-ethnic community, she's passionate, and it shows about addressing inequities and oppression of all forms. She brings a decade of research, policy, advocacy, experience in climate change, health systems, health policy, and collaborative research, and has done a lot to focus on national surgical plans within the Western Pacific. She aspires to advocate and advance equity and planet-centered care through building solidarity across cultures, epistemologies, and histories. So with that, I'd like to turn over to Rennie, who will give us the first talk on her paper, which focuses um, on colonization and its aftermath, reimagining global surgery. Over to you, Rennie.
Great, thanks so much, Banabas. And really, it is our paper that's co-authored by a few of us here. So I'm just going to share my screen now. Can you see my screen okay?
Yes, Rennie. Right.
Okay, I'm getting thumbs up here, which is good. All right. So thanks, Barnabas, very much for the introduction. And it's great to see such an international group in the room today. I myself am from New Zealand, and it's 3 o'clock in the morning at the moment. I've just slept for about 5 hours. If I'm a bit incoherent, please excuse me due to early hours of the meeting, but good morning, afternoon, and evening to everyone around the world. So today we are discussing our paper on colonization and its aftermath, reimagining global surgery. There's been a lot of literature on decolonizing global surgery. There have been studies highlighting empirical inequities in authorship and conference access. In our paper, we approach the topic of decolonization from a conceptual level. We integrated historical and social science perspectives as well as our lived experience. And we wanted to provide a conceptual framework for understanding the inequities described in the literature and by linking it to larger historical processes. We are motivated by the fact that global surgery seeks to advance equity. And we know that global surgery seeks to advance equity by inserting surgical care on the global health agenda, which has been neglected. However, we ask the question, how can global surgery advance equity when power asymmetries exist in both global health and the Western model of surgery? And this is the question that motivated us. So in terms of how the group came together, Issy, Barnabas, and I were co-first authors on this paper, and we were co-fellows at the PGSSC during the COVID-19 pandemic. We came away from the fellowship with the aforementioned question, and in order to answer this question, we gathered a group of our mentors and friends. We were intentional in capturing diversity in location, gender, and profession. So not only did we have surgeons, obstetricians, gynecologists, we also had nurses, midwives, teachers, advocates, and historians. As a group, we represented both the colonizing and colonized people. We were a very mobile and intersectional group, and in fact, our ancestors moved around the world due to the very fact of colonization and its aftermath. We were intentional in that as a small group, we cannot claim universal representation, and we merely represent our specific experiences. And we thought trust was very important to us, which is why we kept the group relatively small. We started by asking the question of what is the change we would like to see? And we actually drew this definition of equity from a paper by August et al. From the literature. And this defines equity as mutually beneficial and power-balanced partnerships processes leading to equitable human and environmental health products on a global scale. So we really liked it, and this was our vision. We defined colonization by comparing it to international collaboration throughout human history. So international collaboration are mutually beneficial exchanges, which are power balanced. They focus on building relationships and cultural exchange and synergy. On the other hand, colonization involves extraction of resources and labor to the benefit of one group at the expense of another. this is asymmetric in power, focuses on products rather than people, and involves cultural suppression rather than exchange. International collaboration is hugely beneficial for health. However, health and surgery has a complicated relationship with colonization. Colonization has caused resource extraction, which has led to the health inequities that we see today. And health, especially surgery, has played a huge role in making colonization morally palatable. So although surgery, as we know, had a limited place in international public health, surgery played a very large role in terms of missionary medicine. Surgery was used to win over bodies and minds, and Peter Parker, a missionary, was said to open China with the point of a lancet. Colonization shaped our understanding of the causes of diseases and the type of intervention that is favored. And an example would be cleft palate surgery, which, as we know, is widely practiced in surgical outreaches. And this is at the convenience of the parties providing the surgery rather than the local population, where other health burdens such as burn care is not addressed as much. And this is all to advance elite academic, commercial, and professional interests rather than the interest of the citizens of the colonized countries. So in terms of our study methodology, we conducted a qualitative group Delphi process. This was done in stages. We started with a review of the literature. The summarized findings were presented to the co-authors. We held a series of Zoom meetings to discuss our lived experience in relation to the literature in terms of coloniality in global surgery. We conducted qualitative thematic coding and synthesis of the Zoom discussion, and we presented the summary to co-authors for iterative input. The meetings were rotated through the time zones, which I think for practical kind of tips is very important for inclusivity, because we had authors across different regions of the world. And the modified Delphi process we used was not anonymous and involved free communication between the group members, which we thought was really important for deliberation and the sharing of ideas. So I think what's worked really well is in this piece, we managed to integrate some of our lived experience as knowledge. We actually started off wanting to do an opinion piece, and one of our co-senior authors said, well, why don't we use this method, and we can actually make the process more scientific and more academic. And I think this was really important because something we see is that some knowledge is counted as knowledge, but others isn't. And lived experience isn't counted as knowledge in traditional Western research. So we wanted to highlight this as a methodology that can incorporate lived experience as knowledge. And there are other qualitative methodologies out there, such as photo voice, autoethnography, and consensus building methods, and many other methods that can integrate lived experience as knowledge. We had no funding, although funding would be really nice to have for sustained group work in the future, and ethics was not required. So using our methodology, we identified 5 categories of inequities in global surgery. These are Western epistemology, geographies of inequity, limited participation, resource extraction, and asymmetric power and control. These 5 categories spoke to the who, what, where, and why of global surgery. And within each category, we had a framework for solutions, which had 2 pillars. One is decolonizing, and the other one is reimagining. So the first category of inequity is Western epistemology. And we observed a conflict between the Western model of surgery and what is required in a global setting. In the West, we are trained to think of surgery as an individualized, specialized clinical skill inside the operating theater. However, in global health, we need a whole ecosystem of care around surgery. As surgeons, we're not only technicians, but we need to build a much wider team. We need to collaborate with other specialties, but also our non-specialist colleagues, nurses, cleaners, our public health colleagues, colleagues in sectors outside of health, such as transport, waste management, and engineering. We need to go out of the hospital into the community and integrate the entire spectrum of prevention, cure, and rehabilitation. In terms of solutions, we need to build more community-centered surgical models around the world. And this has to be driven by not what we can offer, which I think in the Western framework, a lot of our training is suited at our convenience and our skills, but we need to look at what communities truly need and see how we can fit around it. In terms of decolonizing and dismantling, the Western framework and its limited understanding of surgical care can actually limit and quench our imagination. So around the world, we shouldn't adopt the Western model automatically, but rather build local models. And an example in the Pacific is that during the COVID-19 pandemic, when the operating theaters were shut, my Pacific surgical colleagues actually traveled to the outer islands. They conducted public health work, did health promotion, and delivered vaccines in villages. I thought that was a really neat example, and I can't imagine many surgeons in high-income countries doing that. And this really showcases that it's a two-way learning stream. Surgeons in the West can learn a lot from low and middle-income countries. And another example is that my colleagues in Fiji, they routinely do outreach around the country every month. And again, this is something that specialist surgeons very rarely do in high-income countries. So there's a lot that we can learn about how to conduct community-centered surgical care from our low and middle-income country colleagues. The second category is geographies of inequity. We observed that global surgery is not truly global. It remains Western-centric with a unidirectional one-way flow of personnel from the global north to the south. It has a tendency to universalize, with one-size-fits-all solutions favored at the expense of local contextualization. And the solution we concluded would entail localizing global surgery and challenging the hierarchy of values that places multi-centered research over single-centered research, and universality over locality, and also true bidirectional exchanges. The third category was limited or unequal participation. We observed that there's a limited participation of Global South female non-specialist and non-medical providers, and patients and community themselves. And this, in fact, reflects the hierarchy in both global health and the Western model of surgery, because as we know from a lot of other research, the Western model of surgery is very hierarchical. And in order to advance care that's best suited to the communities that we serve, we must have a broad-based involvement of people in the global surgery movement who actually resemble and can represent the communities. The fourth category was resource extraction. And firstly, we observed ongoing resource extraction due to global surgery. Most of the funding were used by NGOs in high-income countries, with very little trickling to low and middle-income countries. And there is a push, especially from the US, on the privatization of industries in low and middle-income countries. There's a tendency to focus on technical and pharmaceutical solutions in global health rather than addressing social determinants. And this is done to create markets for industries in high-income countries. And an example in surgery is actually the surgical devices industry. There have been studies showing that instruments were mostly made in high-income countries. They are costly, not environmentally sustainable, and not suitable to the low and middle income country context. As well as extraction of material resources, there's also extraction of symbolic resources, such as authorship, academic credit, and experience and exposure. For high-income countries trainees who may not be exposed to as much open surgery and advanced pathology, low and middle income countries can be seen as a training ground. Secondly, we also observed resource extraction underlying health inequities and inequities in surgical access and outcomes. And this is not only historical due to resource extraction that occurred during colonization, but it continues to occur due to neo-colonization, unfair trade regulations, and international monetary requirements today. We must not forget this. So in terms of solutions, we need to track resource flow in global surgery. We need to be aware of, but also examine the macroeconomic resource flow and avoid naturalizing material inequities. The last category was asymmetry in power and control. We observed that institutions in high-income countries have disproportionate power and control over agenda setting and knowledge production. And this leads to control over narratives of why global health inequities exist and what the solutions are to address them. This narrative continues to naturalize inequities. So we think about inequities due to geographic or natural causes rather than the human-made resource extraction that occurred due to colonization. And this narrative tends to justify external and intervention at the expense of local solutions. This can only be reversed by strengthening institutions in the global south. And we talk a lot about kind of privatization and as a solution to global surgery, but what's actually not looked at as much is the government current health expenditure as a percentage of GDP. And in the Pacific, with the countries I work with, it's very high in some countries, but low in other countries. And this highlights the importance of strengthening institutions that represent the people and getting them to commit to global surgery. So I just want to share a quote which was written by our co-senior author, Dr. Henry Nqobile from Uganda. So he said, leaders in the global south must take charge of designing, funding, and delivering surgical services oriented towards the interest of their citizens and populations rather than elite commercial or international interests. So reflecting on the process of the paper and recommending directions to go forward in the future, I think the process we followed is good, but decolonizing and rebuilding is not something that should only exist in an academic paper. It should exist in practice. So I think the dissemination of the paper, having discussions like today, and really what we do in practice is the key, because there's no point in talking about it if you're not going to do anything differently. So I just want to share my own kind of experience since I left the PGSSC. So at the PGSSC, I worked on the Pacific NSOPs. When I was leaving, I decided, well, during the second year of my fellowship, I decided that rather than analyzing the data, from the PGSSC, I should give the data back to the countries and work with the countries in a collaborative manner to conduct this research. So we give the data back to the countries, we ask them to appoint surgical registrars, surgical residents, and surgeons. I had a couple of small research grants, and we've been mentoring registrars, residents from the Pacific to co-lead the analysis of the Pacific NSOP data. So on the pictures in the left, you would see two of my colleagues, Chope and Sunda. They are Fijian surgical registrars, and they are looking at the quantitative facility assessment analysis from Fiji. So this is a picture of us at the Pacific Health Research Symposium and a picture of them presenting. And the paper has been written up and accepted for publication. And at the bottom, it's Rajiv and Sonam, who are a surgeon and a surgical resident from Fiji. And again, we are currently working on the qualitative arm of data analysis for the Fiji NSOP. So I just wanted to share a couple of learnings. So when we do collaborative research, we have to accept slower progress and a decrease in personal gain. We ourselves do not need to be in the spotlight. We can be in the back of the room supporting our colleagues. We should be mindful to distribute benefits equitably. So as a part of our research grants, we had data analysis payment to our local colleagues, and that was a much greater amount than what I paid for myself for data analysis. We have to provide growth opportunities, such as opportunities to attend and present at conferences. And the results are actually much more scientifically valid, because I think people tend to sometimes talk about equity in authorship as a tokenistic gesture, but really it is good science. With the Fiji facility assessment paper that's just been published, I've been very impressed by the depth of policy implication and localization, which I think we would not have achieved if a group of PGSSC fellows looked at this data alone. And I think if you're doing good work, there's going to be decrease in personal gain. You might have fewer papers in the short term, but as your reputation builds, it will spread and more people would want to work with you. So I think it's really important that we all commit to this from early stage in our career, because I think 2 years after COVID, I still see papers with no local authorship. I think there has been a slide backwards, and I hear all kinds of excuses from my colleagues, such as, we are doing a systematic review, or we're only looking at survey data. This data requires no local interpretation. So I just kind of really want to highlight that we have to commit to this in practice. And this is the result of our qualitative work in Fiji. So we actually built a Pacific model of surgical care inductively from the qualitative data, which expanded on the Western WHO health systems building blocks framework. So the building blocks consisted a very small part of the framework here. And what the framework also includes is culture, geography, and external shocks such as climate change and pandemic as determinants of health, and population needs, including the cultural needs of the population, as the goal. It includes softwares as well as the traditional hardwares, which are the building blocks. And these softwares include human factors such as helping each other out, being adaptable, improvisation, which have been shown by health system research to play a huge role, especially in health system resilience. And also it includes solutions drawing on Pacific culture, drawing on the culture of voyage across the ocean and collaboration between the islands. So these solutions include regional collaboration, connectivity across the ocean, and mobility of care, doing outreach into the community. So this is what collaborative work can actually achieve. So some final reflections a year on from the publication of the paper. So firstly, as I've already highlighted, it is all in the practice. I think the future is about localizing and getting into the grassroots and building these models of care in our settings around the world. Secondly, I think we've been relatively good at looking at the decolonizing and dismantling part, but we've not been as good at looking at what the rebuilding or the reimagining looks like and what we actually replace the Western model with. And I think to do so, each of us need to dig deep into our culture and history. There's been a lot of trauma around the world over the last couple of hundreds of years with the dispossession of Indigenous people, slavery of African people, and indentured labor of Asian people, and movements around the globe. We need to collectively recover from that trauma, and we need to learn from each other across cultures and histories, not necessarily through the West. Thirdly, I think in global health, we tend to focus on normative determinants. We talk about human rights, the importance of a right-based approach to health, but we pay relatively little attention to the economic determinants of health inequities and the resource extraction. So I think we need to spend a lot more attention on this. We can examine the economic determinants, and we can examine areas that continue to involve resource extraction, such as the surgical devices industry. And I think there's a tendency, particularly from my observation in the US, to jump on privatization and kind of impact investment as the solution. And again, it highlights cultural differences because in my part of the world, in New Zealand and in the Pacific, public institutions are much more important to us. And I think we have to be very careful of the type of economic solutions we provide, because colonization actually largely happened, through a lot of private entities, and strengthening institutions in low and middle income countries that truly represent the people is really important. And there has been a lot of research out there showing that privatization can actually lead to more fragmentation and worse quality of care. I think lastly, around the world, even in high income countries, I think we are struggling with the Western biomedical model of surgery. I recently attended the American College of Surgeons meeting, and I heard about the corporatization of healthcare and surgery in the States and how it's really changed in the last couple of decades. And I think around the world, we have an economic system that doesn't really serve the people and the planet. We're facing an ecological crisis. We have governments that continue to cut health spendings. Health is seen as a liability rather than an investment. We are seeing that with our current government here. So I think we collectively need to shift our economic models, and we also need to shift the biomedical Western model of surgery towards providing what people really need. So in terms of future directions, we need to localize, we need to diversify, build broad alliances outside of surgery. In terms of future research directions, we can conduct historical analysis. We can continue to examine coloniality in specific empirical areas in global surgery. And we must examine economic determinants of inequities in global surgery. But the most important thing is in the practice and in the implementation, we have to be the change we want to see, even at an early stage of our career, and we really have no excuses. So there are some further readings which will be in my slides, and ngā mihi nui, vinaka, molo, opito, and fa.
Oh, wow. Thank you. Thank you so much, Rennie. That's a lot of food for thought, and I'm sure that there are a lot of questions. What we will do is transition to Nqobile's talk, and then we will put together our discussion, have some robust discussion. Before, as we transition, Rennie, do you mind stopping your share? I think that the internet's a bit off. Let's see whether you can share on top of this. But while we're making that transition, I'd like to honor two people who are here, who are the directors on both sides of the Center for Equity in Global Surgery, and the Dean of UGHE is on the call, Abebe Bekele. Just if you could show your face, we can see you. And then Dr. Robert Rivello, another mentor. Thank you, sir. So that's the dean, and that's Dr. Rivello. They make these teams happen. Thank you very much for. So we will move over to our next speaker, who is Nqobile Thango. She's a pediatric neurosurgeon and a lecturer in neurosurgery at the University of Cape Town. In addition, she is a researcher at the UCT Neuroscience Institute under the African Brain Child. Her research interests include neurocritical care, antibiotics in children with brain infections, research education, capacity building. And she and a team of others recently wrote a very expansive and deep paper on the impact of colonialism on surgical training structures in Africa. There's a part 1 and there's a part 2. And for this talk, we're focusing on part 2, but I really would advise everyone to go back and read the part 1, which gives a beautiful history of training structures in Africa and how progress has been over time. And that it's on that foundation that we have this part 2, which is surveying current and past trainees. So Nqobile, it's an honor to welcome you here. I think it's over to you. The floor is yours.
so much. Thank you for the invitation, firstly, and thank you for all the patience. I had issues with my Zoom, and I'm really happy that Prof. Abiba Bekele is actually in the audience. And at the end of this talk, I'm also going to ask him to comment because we worked on this work together, and it's something we hold dearly in our hearts. So the topic we're going to be discussing today is the impact of colonialism on surgical training structures in Africa. And this was a team of neurosurgeons and medical students from the African continent, and also our colleagues outside of Africa from Northern America. So it really was a team impact. It was a difficult paper to also write, and we'll take you through the slides. And, you know, when one speaks of colonialism, it raises different emotions in different people. So I really do commend the Harvard group for bringing up this talk today. So the only disclosures I have is that our funding was received from the JW Equity Institutes at the law school. So as mentioned previously, I will be focusing more on the impacts of colonialism and surgical training structures in Africa, Part 2 paper, but we'd also just really strongly encourage the audience to also look at Part 1, where we deeply go into the history of the different regions of Africa, and it really just helps to pull together what we'll be discussing today. And even in my slides, I will just reflect a bit on the history before we actually go into the results. So just looking at the definition of colonialism, there's a lot of definitions, but one that's commonly used is the policy or practice of acquiring full or partial political control over another country, occupying it with settlers and exploiting it, whether it be economically and lately also in modern day, as scientists and researchers, we know that when it comes to research equity, we also look at it in terms of research and how in sometimes we can promote this culture of overtaking and overshadowing certain areas of the world. So when we talk about, the decolonization is the process by which we become independent. And this topic mainly I'm focusing on Africa, but any LMIC. And I think specifically within our continent, there's this Africa Rising where we're really trying to promote excellence within our continent, specifically in healthcare. So when we go into this is an overview of what I'll be discussing. I'll be doing an introduction and background, then we'll take you through the methods, the results, discussions, and conclusions. And then Prof. Bekele will also just comment a bit before we get into questions. So when we look at surgery specifically within the African continent, it's very nice to break it down into 3 areas. We have our pre-colonial phase, colonial, and post-colonial. So healthcare seeking behavior and surgery on the continent is quite old. So when we look at the pre-colonial time, we know that many areas within Africa, health seeking behavior and treatment was via traditional healers who were highly valued with prolonged periods of apprenticeship and often selected from particular clans or groups due to their knowledge of extensive use of medicinal plants. So there was almost an internship or in terms of traditional healers. And back then, also within our continents, there were surgeries that were being done like trifinations for trauma or infection, incisions and drainage. Circumcision is also quite old within the African culture, and many of these practices persist today. So one of the things you can see is scarifications, which really gets done by traditional healers, and we see it a lot today in our patients where they believe they're draining out or taking out their infection or disease. So early missionaries such as David Livingstone in the 1840s combined a provision of medical care. So many of these missions started coming into our continent to form and start establishing health facilities, and also the evolution of training programs. So when we look at the histological context, we know that we as Africa are quite newly independent within the 19th century. And also surgery within our continent is still quite new, but its legacy is based on our previous colonial structures. And when we look at our training also, we have extra continental training, whether it be Europe, North America, and Asia, which means where our doctors and colleagues leave our continent and seek skills and very few come back. And we think this method of training really propagates brain drain. And then within Africa, we've got intracontinental training, and that occurs in 3 levels. We've got our regional training, and the biggest 3 colleges are CEGS, which Prof. Bekele plays a very good role. We also have the CMSA, the College of Medicine of South Africa, and we've got WACS, the Western African Surgical College. So these are regional training centers. That means surgeons from different parts of the neighboring countries can come and train within these structures. Then we have national training programs, and these are programs that can be offered by different countries. These are localized training programs where they then train and take out neurosurgeons that can work within that specific country. And then there's also local, which are in various regions within the countries that we speak of. So as mentioned before, why does this matter? Africa is a big continent, and within Africa, we have different access to different resources, and a lot of the resources are nestled within the south and northern aspects of Africa. But when we look at training specifically, and our colleagues leaving the continent, if they go into areas where there's disparities, it's very difficult for them to set up practice, and then it promotes the culture of brain drain, where they want to go back to countries where they trained with the equipment that they used to. So that's why it's important, and that's why we strongly encourage and support training programs within our continent versus extra-continental. So what our team determined to do was we wanted to determine the extent to which the type of training undertaken by a surgeon influenced their practice setting and subspeciality. And what we did was we did a cross-sectional survey, and the population we looked at was surgical specialists and trainees, and we administered this survey on Qualtrics for a period of 4 months. We had IRB approval from the CEGS College, and this was dispersed among the various training centers within our continent. So what we aim to do is to explore the current pathways to surgical training within Africa. And we also wanted to report on opportunities and also highlight the barriers to surgical training, and to see what are the barriers also to subspecialty training within Africa, which is still quite new and taking off. So over the course of the 4 months, 1,200 surgeons and trainees in Africa were contacted 3 times to complete the survey. The sections of our survey included demographics. We also looked at the surgical training history, path taken and outcome, and then we divided it into subspecialty training, the path taken and the obstacles encountered. Out of the survey, we had 239 complete responses, and what we accepted as complete was if they completed more than 80% of the survey. So when we look at our results in terms of demographics, they were quite representative of what the demographics are of surgeons within Africa. So it is more male predominant. So a lot of our respondents were male, 13.5 were female, and we think this was quite a high number. A large portion of our respondents were surgical consultants and attendings, and the average years in practice were about 10 years. So we did have a smaller pool of surgical residents responding. So when we look at the survey population, we can see that a large portion of our respondents came from Western Africa, and then this was followed by Southern and East. And when we look at the age group, it's quite a young cohort. So a lot of our responses were ranging between 30 and 49. So these are people that are still early on in their career. So this is just kind of breaking down the numbers and the demographics. So 31.7% of our respondents were practicing neurosurgeons, and the rest were general surgeons, but we also had max vax and urologists and plastic surgeons. 43% of respondents trained through a local training program. 10% we found trained outside of Africa. And of this, 50.2% of our qualified surgeons completed fellowships. Of those completing fellowships, almost half completed it outside of Africa. So just going into our statistical analysis, I won't focus too much on this because we want to get to the results. So what we found interesting is that surgeons practicing in Central Africa were the most likely to have left the region for training. And this may be explained by the fact that this part of Africa still has a lot of issues in terms of the surgical workforce, and they're actively trying to build their health and infrastructure, and countries such as the Democratic Republic of Congo are doing excellent in terms of increasing their workforce. Surgeons practicing in East Africa were the least likely to have left the region of training. And I think this speaks volumes on the work that CEGS is doing in terms of training surgeons within the African continent, and they get exposure to the reality of what they'll be working with and what the burden of disease is. And hence, I think this does mitigate brain drain. Surgeons who practice outside of Africa are more likely to have trained outside of Africa. So this leads to our theory in terms of brain drain. Overall, most respondents desire subspecialty training. However, respondents residing in Southern and Western Africa were both more likely showed a desire for subspecialty training. Respondents residing in Eastern and Southern Africa were less likely to complete subspecialty training, while respondents residing in Western Africa were more likely to complete subspecialty training. But we just need to keep in mind that the numbers were higher on the Western. So this, we felt, suggests that there's a systematic barrier may be present for surgeons training in the regions, such as within the South. They were more likely to want to pursue subspecialty training, but less likely to actually complete it or follow through with it. So we don't know if this is lack of funding, lack of mentorship, conflicts with clinical commitments, or unsuccessful applications. Interestingly, the graduates of UGHE or CEGS training programs are more likely to desire, as I've mentioned, to complete the subspecialty training. Graduates of North American training programs were more likely to also complete their subspecialty training outside the continent, though. The graduates of UGHE or CEGS training programs were more likely, as I mentioned before, to complete their subspecialty training. And when we look at this, when we ask them in terms of the college structures of surgical training, what were the characteristics associated with someone wanting to complete the training, a desire to complete there was a strong correlation for the people that had a desire to complete subspecialty training to actually pursue it successfully. And the region of subspecialty training also had a huge influence in terms of follow through and patient and residents completing their training. One of the perceived obstacles were option to training once they've got their specialities. Where do they go for their subspecialty training? So even when we take to account the region of the residents, the structure of the surgical training is associated with access to subspecialty training and the final practice settings. So to us, this suggests potentially there are addressable causes of healthcare access inequity. And we need to hopefully, all of us on the continent, further study this and elucidate where the differences exist and how the barriers can be addressed. So in conclusion, this was the first survey that was done of this kind, and we really hope that it promotes the culture for more people to do more in-depth surveys within their various subspecialties. So what we found, trainees from certain regions were more likely to complete training administered by organizations local to that region. There was an almost universal desire to obtain subspecialty training, and there did not appear to be a statistically significant difference in the perceived barriers to obtaining subspecialty training by a region. Trainees who left Africa for residency were more likely to complete fellowships in North America and less likely to return home. We know our limitations was a small sample size and poor response rates from Northern and Central Africa. So we hope these findings can be just used as a platform to open further discussions, because our overall aim is to increase the surgical workforce on our continent, to promote a culture of training within. And the only way we can do this is by strengthening our local training programs and promoting regional training programs, which ensure that students get exposed to broader aspects and resources. So, leaving home to go to another African country, you're still going to get the same similar burden of disease, but then you might have access to different equipments and training that you might not have back home. Thank you very much. This was short and sweet, and I'm going to just also hand over to Prof. Begele at this point, just to add any comments he might have.
Thank you, Dr. Thango. Great presentation, by the way, very great summary of the great work you have done. I strongly urge all of us to look at both publications, part 1 and part 2, to get the clear picture of the messaging in the paper. Coming from a continent where the word colonization and decolonization has some serious meaning, I'll be very careful when I make these statements. While doing this study, one of the eye-opening moments is that it gave us a background on what the history of surgery and surgical education in Africa looks like. We heard for the very first time that surgery was being practiced in Africa for the past 150 or 200 years, with clear evidences in Uganda, in Kenya, in South Africa. Surgical education was not new to the continent when colonization occurred. And during decolonization, we also found out, even though it's not in the paper, socialist bloc countries versus the North. Africa was a war zone, and it reflected on surgical education and surgical care. Countries with predilection to socialism, particularly Ethiopia, Tanzania, and some countries, ended up sending a lot of their trainees to Russia, Czechoslovakia, Cuba, and other socialist-leaning countries. There were also, at that moment, countries were dominated by trainees who are coming from the global North. So even though our paper did not dig that out well, we found out that the fight between the North and the socialist bloc thinking was reflected on our surgical education, surgical care. In East Africa, the very first university-based surgical residency program was in Makerere in 1970. We also found out that even though it was called a local training, graduates from the program ended up going to London to take their final exams and then getting their licenses for many, many years, in fact. So even though decolonization was going on in the continent, one can ask, is it actually decolonization? The last point I would like to make is the culture of education in the colonial countries, particularly in Europe, was also seen lingering on in the continent. There are still academic institutions that are taking, their pass rate during exams are less than 25%. Academic institutions that recruit a handful of trainees, where half of them end up being dismissed in the first year, and handful of very competent, quote unquote, very competent people end up graduating. So the legacy of colonialism and decolonialism in surgical education in Africa is still palpable. The details of these are in these two papers. Thank you, Dr. Thango, and back to you, Dr. Banabas.
Thank you so much, Dr. Thango. We will take questions together, and I know that there are many people whose minds are revving right now at the excellent presentation that you just presented, and Rennie also. I think we'll just throw it open. We want to give people online and people in the room an opportunity to be able to participate. So maybe I'll switch questions between the two. And we could start with comments, discussions. You could drop a message in the chat if you'd like, but I'd really like to hear the voices of individuals. We were having a discussion on both your papers a couple of days back, and one of the hard questions that came out is that, okay, I'm hearing decolonization. What exactly does Africa want with the use of the, like, where are we going? What exactly is needed here with all this talk and this rhetoric or buzzword of decolonization? So I think we can start that way and then kick it off. What does the world want? What does the global South want? What exactly do you want? Partnership? Don't you want it? Do you want to pull down and tear and burn all the structures, or don't we need any assistance or any help? We don't want anyone. What exactly do we want? Your thoughts, Rennie?
Okay, very tough question. I think one of the things we need to realize is that we all need each other, the global South and the global North. There's strengths that we have in the South that are not available in the North, and there's strengths that the North has that we don't have available in the global South. So one of the things is when we talk about decolonization, it should be a teamed approach where we're establishing structures that are able to be continued and sustainable within a certain environment. So at this point, there's various fields where decolonization, certain people will say we can do it on our own as Africans for Africa, but we need to realize that we live in a global community and our democracy is still young. And even within the continent, there's great disparities in terms of resources, wars going on currently in our continent. So the aim is for working together as respectable partners, so respectable partnerships, avoiding parasitic relationships where the previously colonized states are being viewed for exploitation of whether it's resources. And today in academia, it's unfortunately data where the global North would have expertise come in, conduct research or surgeries on the African continent, then leave. So what are we promoting? What structures are we sustaining within our continent? And within specifically, I'll speak from neurosurgery, where at the moment have a very strong team within our Continental Association, where we're promoting education and research on the continent. And we are getting great funding from within Africa, from various healthcare systems, investing and realizing there's a need in terms of treating neurosurgical patients. So we're getting a lot of support from health departments locally within our continent, which is a really exciting time. But it's a really difficult question to answer because we cannot burn the whole system down. But we need to also be acknowledged as independents and critical thinkers that know what we want in terms of the future for our population and the countries that we live in.
Thank you, Dr. Thango. Rennie, your thoughts?
Thanks, Banabas. I can't comment on the Africa context, and I'm glad I didn't speak first. I think from the New Zealand perspective, colonization is something we talk about every day. I mean, the country is actively colonized. So these terms are very familiar to us. And actually, in fact, our treaty, so our Treaty of Waitangi, which states that there should be co-governance by Indigenous people, is actually under question at the moment. So there's a bill and we're making submissions. I think from the Pacific, so in the New Zealand context, decolonization means land back to the Indigenous people. It means Indigenous control over healthcare. In the Pacific context, I think something I would share, which might resonate with colleagues around the world, is that, so what I spoke about in my presentation with regards to international collaboration, that's actually deep in Pacific history. For thousands of years, there has been voyage, exchange of culture, trade across the islands. And I think what we've seen with colonization, so there's a Tongan anthropologist and writer called Epili Hoafa, and we draw a lot from his work. So what we've seen a lot with colonization is that colonization has actually divided and isolated the islands. You know, each island has a different relationship. The Cook Island will refer patients to New Zealand. The French Polynesia may refer patients to France. So there's actually division between islands that's created by colonization. And there's a tendency for countries to come in, high-income countries to come in, and they want to emphasize regionalism rather than regional collaboration. So they kind of lump the islands together to serve the interest of high-income countries rather than to, facilitate genuine partnership and collaboration across the islands. So I think in the Pacific context, what it really means is genuine regional collaboration, drawing on the region's history for thousands of years, and actually reframing the relationship we have across the ocean. So rather than seeing New Zealand and Australia as, external partners, high-income countries, we actually see us as a part of the Pacific. So we serve the Pacific. We are here to facilitate Pacific trainees coming here for short-term exchanges, facilitate Pacific patients coming here for overseas referrals, and really adhering to the agenda from the Pacific rather than from high-income countries. So that's what it means in my part of the world.
Thank you. Further thoughts and comments, questions? Trying to see whether there are hands up. In the UGHE ethos, we think of this like a journey where decolonization is one part, but really what we're focusing on and looking to is equity. And I love the slide that you put up, Rennie, about August et al. And Nqobile was also part of that. That sometimes when we look back, we're just tearing down, it's about the oppressor and the oppressed. It's about destroying something, which may be necessary along the journey, but that's not where you're going, right? And so we need to keep our eyes forward. If you were, from your papers, looking at the educational space, and I can relate. I did my residency training somewhere where we were over 200, I think 220 that wrote an exam, first level exam, membership, what COSEX would call membership, and 11 of us passed. I mean, what are we training? How are we training? and no, you should be really proud that you are. Oh, something is wrong. And I think that please, in your paper, you described where we got that from. Now, so just thinking on both your papers, if there was no silver, or if there was something, a primary message that you think should change practice, should not just it's Eleanor Roosevelt that it's sometimes attributed to, but people say it's a Chinese problem, not just cursing the darkness, but lighting a candle. What would that be?
That's a tough one, because remember, our continent is very diverse, multiple languages. We need to also remember that. And also we have, Anglophone and French. So when you're talking about the pass rates, we also need to be very much aware about the way we are training at the moment, and trying to take the context of where people are doing their undergraduate training. So someone might have the knowledge, but due to language difficulties are failing. And then that reflects as the pass rates, but actually there needs to be a more in-depth literature where we look at the background of the current medical school trainings, looking at the influence of language. Should we then, when we move into speciality training, have courses or a pre-course before someone joins formal speciality training, where language and basic methods of medicine are taught, so everyone has equal opportunity and exposure at the same platform before they are tested. And there are centers of excellence within our continents in all regions. And I really do think we need to pull and also rely on the knowledge of our colleagues that come from an educational background. So not healthcare professionals, but people who actually study education, to look at a review in terms of how we're training at the moment, and is it adequate and sufficient for the environment that the doctors are working in. Thank you.
Thank you. Rennie, any thoughts on that before I call on Baylor?
Yeah, I actually had a thought during Dr. Thango's presentation. So with regards to surgical training, I think the Pacific is a really good example. And we've had really strong leadership from the Pacific in terms of driving a regional training scheme, which is centered in Fiji, and all the Pacific Island students come to Fiji to be trained, and then they return to their country for their final year of in-country training. But a problem I'm hearing from my colleagues, especially subspecialty colleagues, is that typically they come to Australia or New Zealand for final subspecialty training after their general surgery training. But the pathology and the exposure in these high-income countries are just not sufficient. You know, for example, as a urology trainee, you might be doing robotic surgery for early stage prostate cancer. It's not the type of exposure you'd need in your country. So one of my colleagues who's a neurosurgical trainee, she's actually looking for South-South learning opportunities and opportunities to go to other higher volume, low and middle income countries to train. Because in the Pacific, a challenge we have is small size and small volume. So I actually had a question about South to South learning opportunities and South to South kind of exchange opportunities. I think that could potentially be a area of light. And I guess the question is how we can work towards that. I think in the Pacific, we have a lot of example of good practice and what kind of indigenizing and localizing actually looks like. But the problem we face is lack of resources and decreased government spending on health.
Thank you so much. There's a comment in the chat that just kind of rides that thought. Tyru saying, I think a majority of African countries need to redefine or define what we really want and make deliberate efforts to achieve it. While we're fighting colonialism from the global north, we still keep doing intercontinental or regional colonialism. For example, since Sierra Leone started its postgraduate training in general surgery, we still go to Nigeria to take the exam. I hold the view that empowering the local training centers will not only reduce economic burden associated with the training, but will increase retention in the surgical workforce. So Rennie, maybe later you'll talk to us about the difference between coloniality and colonialism, because I see that you use that in your paper and what you think is going on here. I will hand off to Baylor Jallo. Hand is up for a question. Over to you.
Yeah, thank you very much, Dr. Banabas, and thank you, everyone. I'm Baylor Jallo, a second-year medical student at the University of Global Health Equity here in Rwanda. So the presentation was very good, but I have two crucial questions that I'm thinking in mind right now. One of it is about, I took them down. One of it is about power and knowledge dynamics. How do historical colonial power structures influence who defines surgical knowledge and practice globally? Like, are training programs prioritized to needed to the context of the global south, or are they imposing system rooted in the global north model? Thank you. I hope you get my questions.
Rennie, I think you talked a bit about that, and Dr. Nqobile.
Does Dr. Thango want to go first, because it's more relating to training?
Sure. Yes, so different training systems will prioritize their population, the pathology within their population. And also resources have a very huge play. Surgery is expensive. It requires equipment, it requires resources, and it requires strong healthcare systems. So that's one thing we need to acknowledge. So even the comments about our colleagues discussing Sierra Leone and Nigeria, we should more view it that initially, while building your workforce, you rely on African countries that do have established training centers to train your residents. And one day your specialists, once there are enough, and can motivate with their local healthcare facilities to get the equipment, because you can't train residents if you do not, for example, neurosurgery, have a microscope, neuronavigation, MRIs. You really need a robust system, and it's expensive. So instead of maybe viewing it negatively, that it's a second point of colonization. The colleagues that are coming from countries that are less resourced, they're moving into those environments. They're still seeing the same patients they would see at home. Because remember, in Africa, what differentiates us from the North is where our pathology comes very advanced. Our tumors are usually very big, and we deal sometimes with very sick patients because healthcare seeking behavior is different. A lot of the times people will go the traditional route, and also access to specialized healthcare is expensive. In some areas on our continent, patients have to pay for the antibiotics. They have to pay for a shunt if the surgeon's putting it in. I know in South Africa, we might not be in that situation. We do have, universal free healthcare coverage, but in other countries, healthcare is expensive. So I just think for us, we should actually prioritize the regional programs and training within Africa, and ensuring resources are directed into that, and then documenting and ensuring that the workforce is increasing in those vulnerable population groups, so that when the numbers are sufficient, we are then able to support them in advocating for resources and establishments of training programs within the country. I must say I am against extra-continental training, because then people will not come back home. And it's the reality. You have children, you want a better life for your family. There's a lot of complex situations that comes in terms of leaving home. And once you've left, how do you come back and help? Because you're now disconnected from that healthcare service, and you're disconnected from the local doctors. So really relying on regional training programs at the moment and ensuring that they're sufficiently funded. Thank you.
Thank you. Still, okay, Rennie has a response. There are a couple of questions.
I think I'll respond to the first question, which is around the power-knowledge dynamic. And I just want to give a couple of specific examples from my experience. I think there's a lot of coloniality in kind of knowledge in surgery that we still see these days. So I think one example is quality of care. So a lot of surgical quality markers that we see in high-income countries, they are very narrowly defined. For example, quality markers for colon cancer may focus on the actual surgery itself, your resection margin, your complete resection, which is really important. But I think what we don't look at a lot is, are patients actually getting the care? Are they actually able to access care? I think a lot of quality is kind of defined and controlled by high-income countries. And within high-income countries, there's inequity. These quality markers are controlled by tertiary centers in the cities rather than rural areas close to the community. There are guidelines and standards created by high-income countries. So suddenly, if you're from a low and middle income country, if you don't have access to resources to achieve these quality markers, you're told that you have poor quality care. Which is really demoralizing. And I think quality of care needs to be much more broad, and I think access is really important. And I worry that there's probably a shift globally towards more taking care kind of further away from people and centering care perhaps a little bit too much in some circumstances. So actually it was really interesting. When I came back from my fellowship, I was all fired up about decolonizing. I came back to my hospital. We had an educational session for residents, and one of my professors was giving a talk on quality of care. And every single person he cited in his talk was a white man. And I just really felt like I was taking a step backwards. But this is the reality we face. I think this is what Professor Abebe spoke about earlier, is that the Western model and the way we are trained to think, the resources we draw on, the references we use, it's still very Western centric. And I think I see a lot of innovation from the Global South, especially in the sustainability and climate change space. There are a lot of surgical practice in the Global South, which is actually much more environmentally sustainable. There's devices, innovation in the Global South. So I think what we need to do as a collective is to document and highlight the knowledge that's created in the South, and bring them out into forums. And I think another example of knowledge power is that so in New Zealand and in the West, we tend to focus on individual responsibilities for health rather than social determinants. And I see this being used against Indigenous patients quite a bit. You know, people would say this patient's not fit for surgery because they smoke, because they do all these terrible things for their own health. They don't take control of their own health. But this is neglecting and ignoring the harms done by colonization and the fact that these patients live in poverty with poor social determinants. So I think another way in which power can shape knowledge is that it diverts our attention on certain causes over other causes. And this, in response, shapes the type of intervention we provide. And it justifies not providing adequate care to certain parts of the population.
Thank you, Rennie. So that's around the whole concept of epistemology. Dr. Thango, there are a couple of questions around the methodology of your paper there. The first is why you think the response rate is low. And then in line with that, Dr. Rivello, that was from Dr. Mulugeta Tena from the UGHE, and then Dr. Rivello from PJSS is asking in follow-up, can you tell us about the methodology of identifying the trainees? How did you get the specific trainees and surgeons? And how
so that's
can
a very good, yeah, that's a very good question. Our response rate was low. So I'm just going to start off how we identified and dispersed the survey. So we did it via the various regional training colleges. So we got the databases from the various regional training centers. And this might introduce bias because it may mean that we did not reach people that are within the national training programs. And also specifically within Southern Africa, when approaching the CMSA, the concept of colonization is a very sensitive topic within our country. And also certain educational structures think very deeply when it comes to integrating themselves with various research projects, because what is the outcome going to look like? So one of the hindrances we may have had is we did have a bit of difficulty dispersing it between our CMSA college. The people that did very well was the Western African colleges, because we had a colleague that was active and secretary, I think, at that point in the college, so they could push the driving forces through. And specifically with our content in the Southern, I had to heavily rely also sending it through the various department heads and hope that they will disperse it. So the database from the South was limited. And CEGS was very kind to also share their database, so it was easy to access. So here we left out national colleges specifically and local training programs. And how we can improve in that is opening up discussions where we look at colonization and we're not pointing fingers, where we're trying to take the white man down, or we're trying to dominate, or there's power struggles. And so I think we really need to go through the concepts of educating people what decolonization means. I see Prof. Habibe's hands up, so he'll comment. What the word decolonization means, and having honest discussions with our colleagues about taking the way forward. So we didn't reach, I think, enough local and national. We were mainly relying on regional databases, and hence why I think also our resident pool was very low, and WACS and COSEXA were able to disperse it better than CMSA and Northern Africa. Prof, I'd also like your comments on that. Prof. Begele.
Thank you, Dr. Thango. Well, in fact, to respond to Baylor's question at the beginning, and to add on to what you just said, I think we need to first ask ourselves some tough questions. What do we need to do in Africa? What are we doing? Do we know how many surgeons we want in our specific countries? How many general surgeons? How many urologists? I know specialty and super specialty in the global north is a trend. One should also ask that tough question. Do we need subspecialty in Africa? When 95% of the African population does not have access to surgical care, and these are in the neglected, underserved regions, and a general surgeon is the best cadre to treat these patients, And countries are so focused on specialty and super specialty. Are we doing the right thing? I know I'm going to raise a lot of controversial issues, but this is where I think we should start. What kind of surgeons do we need? How many? When? Let it not be about ourselves. Let it not be about the profession. Let it be about the people we are trying to serve. Since 2014, many research papers start with this statement: 5 billion people lack access to surgical care. It's probably true. It's probably true. And if we repeat such a modeling now, I suspect the number is going to increase. That means what we are doing now is probably not right. Things have to be changed somehow. So the very first thing to do is understand what we want. What do our countries want? What do we want? Then how do we achieve those goals? We did a certain modeling in regards to cardiothoracic surgery in Africa. And we kind of modeled, we did 185 years in the COSEXA region to reach the cardiothoracic to patient ratio. 185 years. I mean, is that even a number? In terms of SAO density. So I don't like the word decolonization. I want to use the word equity, because as you said, Dr. Thango, colonization comes with a lot of political terminologies. You have to kill someone, you have to destroy someone, you have to get rid of something. I don't think we're trying to do that. I think we're trying to learn from the past, the history. What can we retain from that? And how can we radically change? So Baylor, I would focus on that. Yes, most of our curricula, most of our teaching is Western-based. For the right reasons, or maybe the wrong reasons, you draw your own conclusion. But the history tells us the system is put in place not to serve Africa. It's to serve a certain group of people. That's what history shows us. Probably the history that started in 1884. I would like to also draw a historical parallel to the Flexner report, the main history of medical education in the US. That's supposed to be a landmark report in medical education, but look deep. Look deep. What happened after the report? Didn't 80% of the Black medical schools in the US shut down? Didn't medical education completely change? Completely unrecognizable. So whatever benefits there are in a system, one needs to ask those tough questions. Is that serving us at the moment? And do we need to change? Let me pause here, Dr. Banabas. Thank you.
Thank you. Thank you so much, Dean. We've not heard a lot from the room. We have 5 minutes left. Rennie, you have one question in the chat. It says in the solutions to mitigate inequities, you suggested leaders in the global south should design, fund, deliver surgical care that aligns with the needs of their citizens. What strategies do you suggest? Maybe just like in a minute. What strategies do you suggest should be employed to motivate them to do so? Over.
Thanks, Banabas. That's a very tough question. I think just briefly, I observe that a lot of our governments are still extractive, not only in low and middle income countries, but high income countries. I can't speak on this, and I would love to hear the expertise of the room from Dr. Thango and Professor Bebe. From what I observe from the data and what I hear from clinicians in the Pacific is that the government, I think a good starting point will be being responsive, actually listening to the people. From political science studies, we know it's good having a broad grassroots base of clinician involvement. And in certain Pacific Island countries, for example, in Fiji, we actually have that with a clinical services network. And having that a broad-based grassroots clinician input and having a direct link to the government from the clinicians. So that's what I know from my experience, but I don't think I'm the best person to answer this question. So over.
Thank you. Thank you very much. If we have thoughts, maybe really briefly, Dr. Key Park also has a question in the room. Any
amazing
additions?
conversation. this has been
Wait. Can you hear us? Can you hear us?
Yes, we
Yeah,
can.
yeah. This has been an amazing conversation. So let me first, good to see you, Nqobile. I'm gonna give you a question, and then you can ponder on it while I go to Rennie. If you had $1 million and say, do something to change the face of training in Africa, how would you spend it? That's the question for you. Then I'll come to Rennie. Good to see you, Rennie. It's so good to see that you're continuing the work of the PGSSC, even after you've graduated, like Barnabas. I really like the one slide where you show how you were practicing the collaborative research, where you actually yielded a lot of your academic recognition for the benefit of the people that you're working with. That's a very tough decision to make, especially someone young in the career, right? What advice do you have for people of your peers? How do you process that in your own mind?
Thanks, Key. Yeah. So after I came back, I actually had a conversation with one of my mentors. I think academia is also different around the world. And I think in the US, there's a particular focus on productivity. To be honest, when I came back to New Zealand, I carried some of that with me. And I had a mentor, and she's quite a very good advocate for equity in global health. And I kind of sat her down, she sat down with me, and she was very honest with me. And she said, you know, you just cannot carry on doing the same work. And, you know, morally speaking, in 5-10 years' time, would you really be happy to look back and look at your paper and see, you know, no local first author and senior author? So I agree, it comes, you know, it may come with some pain initially, but it's the right thing to do, and we have to do it. You know, we can't live without moral conscience. And really it yields much better quality of research. And sure, I may have a few less publications, but I have all the privilege in the world, so I'm not losing anything.
Thank you, wonderful question. So one of the things one would do if they had $1 million, what we'd look at, and I'm going to speak specifically with neurosurgery, because with cardiothoracics and others, I'm not sure, but it would be channeling training opportunities and sponsorship through high input centers of excellence in the region. So promoting regional training. So for example, we know with the South, we've got South Africa, in the West, we've got Cote d'Ivoire, Senegal. In the East, we've got Kenya, Ethiopia, Northern Egypt, Morocco, very high input centers, large of numbers, getting funding for students that are coming from countries where there are less than 10 specialists to go and train. For example, in South Africa, we have supernumeraries. That means they come from other African countries. They get zero funding from the Department of Health of South Africa. They come here to train, and they rely on funding from back home. And what often happens is the money runs dry, and people are left destitute, hungry, and trying to train themselves. So if we had formalized training opportunities where we fund through these local centers, with high, because they need to, first of all, have the correct equipment, be able to train, have the proven record of training efficient surgeons, and then ensuring that we are channeling residents through that, where they are focused on training and not bread and butter. Because what happens is when the money runs out, then what happens in our situations, a lot of the residents do what's called locums. That means they work overtime. So on top of doing your hours in your subspecialty, you will go work at a clinic and be paid doing GP work, and in the morning go and compete with someone who's had a full meal and sleep and write exams. So how are you expected to perform? What are you getting out of that training opportunity? So that's one of the things, focusing regional training and ensuring that scholarships are given to areas where the workforce is deficient to be trained through those centers. Thank you.
Thank you so much. I'd really like to appreciate our two speakers. If you have a virtual hand clap, please do that for them, those in the room. Physical pump. Thank you so much. Thank you for joining us from all over the world. We're done. We're over time by a couple of minutes. I'd like to share this quote pulling this tarpism, this quote pulling from Baba Tarp. For every complex question, there is an answer that's clear and simple and wrong. So some of these things are really complex. They're really complex. Thank you so much. Please remember to join us for our next webinar, February 13th, 2024. And you have to register for the webinar event each time to prevent Zoom attacks, but we'll send you reminders ahead of the event. Thank you so much, our speakers. Thank you, everybody, for making this first seminar a success. We're grateful for having you. Bye all.
Bye.
And Mina, could you put your email address in the chat so that we can get your comment to the speakers? Thank you.